What's up, everybody? Welcome back to my channel, Pace the Pants. Today, we're going to be going through acute coronary syndrome, walking through the clinical guidelines from head to toe when the patient walks into the emergency department, the symptoms that they have. Let's go ahead and go through it together. So, first thing is the patient is going to have ACS-like symptoms. So, what kind of symptoms do you think those would be? Yeah, so they're going to have chest pain, they're going to have dyspnea on exertion, kind of the classical anginal type symptoms, okay? Now, when that comes into the door and you suspect that they have chest pain, what's the first thing you're gonna wanna do? Well, you're gonna wanna do a primary assessment. How serious is this? And what labs and tests do we need to order? So the first thing that needs to happen, within the first 10 minutes of them arriving to the ED, we're gonna get them an EKG. Also, while we're at it, let's go ahead and put the order in for some basic labs. So that's going to be a CBC and a BMP. Okay, we're going to want to check their blood. We want to see what's going on. Obviously, we're going to want to order troponin and that kind of stuff too. But let's go ahead and continue onwards with our flow chart. So after we get our EKG within the first 10 minutes of arrival to the ED, we order some basic labs. As a reminder, we could do the troponin. So first, we're going to want to get the troponin about as soon as we can. And then we're going to get troponin again 60 minutes after their arrival as well. So make sure we get the troponin levels. That's going to check and see if we have breakdown of the cardiac myocytes. And that's going to help us confirm our diagnosis, whether this is serious chest pain, whether it's angina, unstable angina, Prinzmetal angina, or an NSTEMI or a STEMI, as well as the EKG is going to help us. Next, we want to also consider getting a chest x-ray. That's going to help us determine if it's chest pain that may be from a pneumothorax, chest pain from pulmonary embolism, maybe chest pain because of bronchitis or pneumonia. So we want to get a good clinical picture. We can see if there's cardiomegaly. We can check out the lungs. So consider ordering a chest x-ray. Also consider getting PT-INR and a BNP if you're concerned for congestive heart failure. And depending on the clinical picture, whether or not you think a D-dimer would be necessary. Also, obviously at this point we have IV access. Now, let's continue on. So next on our flow chart, we have clinical information to decide how serious is this. Is it a STEMI? Is it an NSTEMI? Is it some kind of arrhythmia? Or is it some other kind of diagnosis? If it's a STEMI or an NSTEMI, then that's going to be a different kind of video. If it's not a STEMI or an NSTEMI, however, it's chest pain, maybe the patient has the risk factors for acute coronary syndrome, then we can continue on with our flow chart. So next with our flow chart, we want to do primary treatment. This is primary treatment because the patient has not had a heart attack. The patient has not had a STEMI or an NSTEMI. So we're preventing those events from occurring. For primary treatment, you want to think of things such as aspirin, 81 milligrams. If they're in the ED, we can give them that one dose of ASA right then and there, and then they're going to possibly go on a daily aspirin, 81 milligrams. We want to give them O2 if their O2 stat is below 90. And then we want to give sublingual nitroglycerin for that chest pain. After we give this, we can monitor our EKG, make sure that the patient does not have a STEMI or a STEMI, and see if that primary treatment helped. Lastly, getting them ready for discharge. The patient did not have a STEMI or an NSTEMI, and let's say our patient is high risk. So maybe they have advanced age, diabetes, atherosclerosis, previous TIA, PAD, modifiable risk factors are present, such as obesity, poor lifestyle, not enough exercise or walking, their diet. All of that information we take and decide whether our patient's high risk. We can do an ACSVD risk score and check that to see exactly how much of a risk the patient has. So that's ASCVD. Okay, so you can look that up through the American College of Cardiology. So if our patient is high risk, we're going to give them a statin. So we could do atorvastatin, 80 milligrams. We can do, we can consider low molecular weight heparin or unfractionated heparin if we're concerned for some kind of clot. That would be anticoagulation. Again, that's only if it's necessary. And then we can consider nitroglycerin infusion. Maybe if our patient still has persistent chest pain, we're seeing some concerning things on the EKG, perhaps not quite a STEMI or an NSTEMI, but something more concerning. And then we can also do a beta blocker, such as metoprolol, 50 milligrams. And then we could do one dose of either clopidogrel or ticagrelor. So I'll just write antiplatelet. And then consider admission. So this is a basic flow chart for an ACS picture. If this helps, leave me a comment down below and I can make more flow charts to walk through typical presentations that are common for PA students in their clinical rotations. Thanks for tuning in, and we'll see you next time.